at the end. I don't actually know how to get to the chat as I'm showing the slides. Otherwise, I would encourage them all the way. But I wanted to give a brief overview of childhood cancer. As Tara mentioned a few minutes ago, people consider it rare, but it's really not. About 15,700 children are diagnosed with cancer in this country every year. So that's about 43 children a day, which is over one classroom full of children. And about 15,000 children are on treatment at any given time. Treatment could last from as little as a couple of weeks to a couple of years, sometimes even longer, and can include things like surgery, chemotherapy, radiation, immunotherapy, and more. We've seen the survival rate for childhood cancer as a whole improve drastically over the last 50 years, from less than 10% to over 80%. Unfortunately, some childhood cancers are not equal to others, and while some have survival rates at or above that 90% mark, others still have survival rates of under 1%. And speaking of children who do survive, over 60% of children do face long-term side effects of treatment. And this number is probably very underestimated. Some more recent studies are saying closer to 90% that we're seeing. And that goes along with what we see here in the field. And these effects can be cognitive, physical, emotional, all sorts of different things. And we'll talk a little bit more about that when we talk about school and children with cancer. This is a little infographic from PureSearch that shows the types of cancer children tend to be diagnosed with. The most common kinds of cancer children are diagnosed with are acute lymphoblastic leukemia and brain and central nervous system tumors. So that's what we see the most of, but we also see everything on this pie chart here. You can see it goes through many, many different types of cancer and different systems. And as Tara mentioned in her talk, I'm going to be saying that a lot, by the way, because she covered a lot of what's in mine, which is great. It's good reinforcement. Cancer is the #1 illness cause of death in children in this country, of children ages 1 to 19. Under 1, I believe it's still cardiac causes. So we still see way too much. We see too many children coping with this, too many children not surviving it as well. As mentioned earlier, I work here at the Valerie Fund Children's Center at Goryeb Children's Hospital in Morristown, New Jersey. And our staff here includes physicians, nurse practitioners, we have a dietitian, nurses, we have a neuropsychologist on staff, we have 3 social workers, child life specialists, research team, as well as our front desk staff. We also have an educational liaison position. Much of this presentation was written prior to the pandemic. So there will be a couple of times I'm going to have to alter things. Prior to the pandemic, we did have integrative medicine present every day. So we had massage therapy and acupuncture available to our patients and their family members, because we found that that helps quite a bit with all of the side effects that they're experiencing, and for parents, a lot of the stress. And for parents also, one of the side effects that we don't really talk about is for particular parents of toddlers and preschoolers, the physical toll have them and not be able to get all those services that they would have. Okay. Preschoolers. Little disclosure here. I love our preschoolers. This age offers us so much in development. We have our pre-operational preschoolers who are in that initiative versus guilt and that information seeking. I call it the why stage. Why is the sky blue? Why is the ground brown? Everything is a why, and it doesn't ever seem to stop. And that doesn't stop when they're faced with a medical experience. They want to know everything about it to some level. So this age, we see 3 to 5 or 3 to 6 years of age, and they actually need answers to their questions, because that's that initiative versus guilt that plays into that, where they need to feel validated that they're okay asking and they're not being a nuisance. This is also an age where they should be playing with their peers and learning that those social skills that come with those peer interactions, which is very limited in the hospital, particularly right now. They tend to engage in magical thinking, and this comes out in the hospital setting as blaming themselves or other people for an illness, or blaming something totally unrelated, like I didn't eat carrots, so I'm sick. Or I kicked my brother and I did something bad, so it's my fault that I'm sick now. They may blame parents, they may blame siblings, they may blame totally random things. But this enforces the idea that they really need to be given information on a developmentally appropriate level so that they can understand. Children this age continue to be afraid, I went right ahead, afraid of separation from their parents and of pain. There's a loss of autonomy that can cause a lot of issues. Anybody who has ever met a toddler or a preschool or a 3-year-old knows this. They may need explanations over and over again. So when they're questioning, adults can get easily frustrated and think, I told you, we had this conversation, I told you this already. But that's just processing and how they're trying to sort of bring that knowledge into their world and assimilate it into what they know. They also need really concrete language. They have a really hard time with vague or abstract language, and that can lead to misconceptions and fear. And we'll talk about that a little bit further because that kind of goes across the board with children, but this is the age where we definitely see more confusion with language. So moving on to our school-age children, our 5 to 12-year-olds, about latency age. They're in that concrete operational stage, dealing with industry versus inferiority. Competence and peer group affect their confidence. As you can imagine, when a child is diagnosed with cancer and they're undergoing treatment, they're often separated from their peer group, which can have a direct impact on that confidence. At this age, they also have a greater understanding of how the body works and illness in general, as compared to the preschoolers before them. They continue to fear pain, also fear harm to the body in the form of disfigurement and mutilation. This is an age where we also tend to see an interest beginning or continuing into gory Halloween type things. So they can come up with some pretty interesting ideas in those imaginations about that disfigurement and mutilation. Again, clarifying that they need that correct information. They tend to start fearing illness. They have a greater understanding of death in general and can fear their own response to their illness. When children are hospitalized at any age, or really people, there's a lot going on that can cause a loss of bodily control, bodily functions. We pump people full of IV fluids. There's medications that cause different bowel and bladder issues. And loss of bodily control can lead to shame and frustration that we often see in our younger kids, but is escalated in this age. There's a lot of loss of competence where children are not doing things for themselves that they normally would do. We are quick to jump in and do things for them. And this can lower that confidence, like so many of these other things. We see this also with an increasing dependence on others, even though this is the age where they should be shifting towards more independent skills, whether it's bathing, eating, toileting, depending on help from parents and nursing staff. Magical thinking we usually consider to be a preschool trait, but I'm a firm believer that we see magical thinking throughout the lifespan to an extent, because we do see our school age patients who blame themselves or their parents for their illness. And some of this may have to do with their knowledge of cancer and equating it to cancer in adults, where sometimes, not always, but sometimes it can be linked to a cause. And we come to our adolescents who are in that formal operational stage and figuring out who they are, that identity versus role confusion. They have an understanding of abstract concepts. They understand the uncertainty that comes with a cancer diagnosis. They continue to fear bodily harm, including mutilation, but also body image. There's a lot of body image things that come up with a cancer diagnosis that are very real. They still fear pain. That's just a human thing. And then they fear loss of identity and how this will impact their future. There's often a loss of social support. This is an age where adolescents are gravitating towards their peers for support in general, but they may be finding that their peers can't offer that support because they really don't know how to respond or how to help their friend who's dealing with illness. We continue to see forced dependence in a time of needing independence. Our newly licensed drivers are told they can't drive for a time period or can't drive after procedures or chemotherapy. They may be leaning on their parents for help with things that they haven't needed help with in 10 years. We also see a lot of privacy concerns at this age when they're needing their parents for more help or nurses to get involved with things that they wouldn't have needed help with before, and then also within the hospital. I wish I could say that there's a lot we can do for that, but that does tend to be prevalent. And then we have our young adults. This category, our adolescents and young adults, are often looped together, but our young adults are in a new stage of development. They're in that intimacy versus isolation, where relationships and forming those relationships are so important. But the cancer experience often makes relationships difficult, to meet new people, to have relationships, to continue relationships. Our young adults have fully functioning minds and they know the reality of cancer and a cancer diagnosis. Fear of death is common. There's fear of loss of livelihood. And illness often stagnates our AYAs, our adolescents and young adults, because they see their peers moving on. They see their friends graduating from college, getting jobs, moving, settling down, while they're still feeling pretty stuck in coping with their everyday life with their illness and not doing those things that somebody their age is often doing. We also see some things come up when they're treated by pediatric specialists, because this could be comforting, but it can also feel very restrictive and juvenile. So it's always important to, try to do whatever we can to prevent that from happening, or make a space for them that is for them and really speaks to them in our centers and children's hospitals. They also have logistical concerns that our younger patients aren't so worried about, that their parents usually worry about: the health insurance, work, tuition payments, that kind of thing. As Tara mentioned earlier, childhood cancer really affects the entire family. So I want to talk about siblings for a moment, because siblings have their own psychosocial issues that come with a childhood cancer diagnosis. They often feel jealous of their sick sibling. They may feel anger, frustration, loneliness, sadness, fear, and guilt. They're often shuffled around between parents and other caregivers. They're often not at home. They may be moving house to house as different people take care of them. They can feel a lot of guilt once they're feeling those feelings towards their sibling, when they're feeling angry or jealous. And then they feel guilt because they know it's not their sibling's fault, but they're still feeling those feelings. They may act out in search of attention, and they need education and support around the illness, just like their sick siblings receive, and they don't always get. They're also often treated as an accessory of the sick child, and this is something that I can't tell you how many siblings have mentioned about being in school or in the community and everybody coming up to them and saying, "Oh, how's your sister? How's your brother?" and not asking them how they are, or kind of forgetting that they're their own person and not just there to report on their their sibling with cancer. And just as siblings do, parents come into this and are faced with psychosocial concerns as well. We have to remember that we meet parents at some of the worst moments of their lives. So we don't meet parents when they're feeling their greatest. We meet them when they're feeling their worst. And everybody comes into this with different coping abilities and mechanisms, different ways of getting through difficult things. Parents are forced to learn a new world overnight, often, a new vocabulary, to learn to speak another language, to speak that cancer language and that hospital language very, very quickly. They're given so much information in such a short period of time and asked to make decisions that seem impossible to make at times very quickly. Parents are often dealing with work-related issues. It's not always possible to leave work to care for a sick child if the health insurance is dependent on a parent, or if a parent is a sole provider. Most families have to have one parent stop working or take a reduction in hours just to be able to take care of the sick child. Parents often live in a state of hypervigilance, and that's not just through treatment. And I think Tara alluded to this as well, that it really does continue after treatment ends. And I couldn't tell you when it actually ends, because I'm not sure it does. We find that marriage difficulties are not uncommon after a diagnosis too, because of the stress that this places on a family. As a whole, families are often broken up. There's not a lot of time to connect. They're in different pieces where one parent may be with the child in the hospital and one parent may be with the siblings at home. Financial concerns definitely affect everybody in a family. That we'll talk about more in just a moment. But we also find that extended family members are affected and are not always taken into consideration like others. Grandparents in particular, we see deal with a lot of grief. They have grief over the grandchild's illness and then their child's sadness and fear concerning that illness. So they're often in need of some support too. Check the time, okay. For the financial aspect, even with good insurance, some families are faced with horrendous bills. Co-pays can add up to hundreds or thousands of dollars per month. We have some families whose child needs radiation and they need anesthesia for radiation because they're an infant or a toddler. And they may have $100 copay for that insurance and they're doing radiation for 5 days a week for 6 weeks. Hospital parking alone can add up. Food on the go, babysitting for siblings, that all takes money away from other needs, as well as the over-the-counter medications, the copays for medications, and all the medical things that come up. Financial concerns usually last way beyond the end of treatment as well. So now we'll talk a little bit about how we help children and families through this experience here at the hospital. We have a psychosocial team here that includes social workers, a child life specialist, education liaison, and psychologist. I'm going to focus more on child life specialists because that's what I do, and I'm going to share a little bit about what I do on a daily basis to help the children here cope and learn about their illness and learn those mechanisms that help them to get through and make it hopefully not be as bad as it could be. Let's see. So one of the first things we do with children is diagnosis and treatment teaching. And we give children, even as young as toddlers, some basic explanations. We have an honesty policy here at our hospital, as most children's hospitals have. We fully believe that children need to be informed. They need to know what's going on in a developmentally appropriate way. And they need to be a part of their treatment team as much as possible. So we do encourage the use of proper words like leukemia, cancer, chemo, and we avoid euphemisms. We note that adults are often afraid to use the word cancer, as was noted earlier. The C word, as people will say, or they'll drop their tones when they say it. But children don't come into this with the same experience that adults do, and they often don't have that same fear of the word. So we want to make sure that the words are used because children hear everything we say. We think that they're not listening. We think that they're busy in the iPad, but they're really hearing us. And it can come out at the craziest times too sometimes. I'm going to show a picture, and well, we're a little basic with our teaching materials here, not very high tech. So these are wooden cells that I use to teach children. These are actually blood cells, but we do have cells for different parts of the body. And I often use these cells to teach children about what's happening inside their bodies. These or cells in general are not often known to children, our preschoolers, our early school age children. They learn about cells a little bit later on. So I explain cells as being the building blocks of our bodies. We can't see them with our eyes, but we can see them when they come together to make something, often like Legos. And I actually, when I do school visits, I used to bring in some Legos and show children a bag of Legos that hadn't been put together, and then something put together to show how those blocks can become something. But it all kind of backfired when they started critiquing my Lego building skills, and that was just not good. So I stick to my regular cells now. But I explain how our skin cells come together to form our skin. Our muscle cells come together to form our muscles. We do a lot of hand motions. That's why they're coming out right now. These in particular are blood cells. So we have our white blood cell. He's the police officer of the blood who fights off germs, like when you get a cold. We have our red blood cells, and those bring oxygen from the air that we breathe around to all of our organs. and our platelets, which are our sticky cells that stop us from bleeding. And I explain cancer or leukemia in general when using these blood cells as cells that aren't supposed to be there, cells that have no job, lazy cells like Tara said before, cells that just get in the way of these cells doing their job. And that gives a tangible way for the children to see and feel like they can play with these cells, come up with a dialogue with these cells, and begin to understand what it is the cancer is and what we're doing to get rid of that cancer. So it's a little bit about teaching. Okay. Along with diagnosis teaching, we do a lot of preparation for children because we know that prepared children are less afraid, and children who are less afraid are much more likely to cooperate. So we provide developmentally appropriate procedural preparation using dolls, props, loose parts, a lot of photos, sounds. Sounds are important for anybody having an MRI. If you've ever had an MRI, you know what it sounds like. It's crazy that you can to think that a medical test can sound like that. So we have children listen to that sound ahead of time so it's not so scary when it actually happens. And then we do a lot of verbal explanations. The important things are what the child will feel, see, hear, smell, and taste. So covering all of the senses. This shows some of our preparation materials. This on the, I'm assuming that you're seeing it the way I am. On the left is a port, and a portacath is a device that people can get chemotherapy through, other medications, fluids. It's implanted in the chest, usually in the chest, and accessed with a needle. And being able to see a port and play with a port allows children to have some mastery over what's happening and understand a little bit better of what device is being put in their body. So that's just a port book next to it. And then we use a lot of dolls with medical tools that we sort of make ourselves. This doll was used to prepare a child for a nasogastric tube, the nose. As we are talking about illness and procedures, we want to be very, very careful about our language use. Children understand information differently based on their developmental stage, which we always keep in mind is not necessarily on par with chronological age. So 2 8-year-olds may have very different understandings based on their developmental age. We know that children and adults are often confused by medical jargon, but we also know that there are some common misconceptions for children. Words like flush. So in the hospital, we use saline to flush IV lines. But prior to the hospital experience, think about your only connotation of the word flush, or your first connotation of the word flush. It's a toilet, right? So we see that with children who are confused about that word flush and get very, very concerned about what's happening to their line. Other words like dressing can be confusing. I had a 6-year-old who was he got his port accessed with the needle for the first time, and the nurse was going to put a bandage over it to keep that safe. And that bandage is called dressing. And she said, hang tight, I'm gonna get your dressing. And he thought it was the funniest thing in the world. He's like, wait, is it gonna be a kind I like ranch, or are you gonna give me a yucky kind? So he was equating it with salad dressing. He's a bit of a clown, so it became a thing after that, but it is a common word that children are confused about. Another one could be kidneys. There's a story here within our hospital about a child life specialist who had to clarify kidneys for a child who thought he knew what they were because he's a kid and he has knees. Not exactly what the doctor was talking about with kidneys, but she was able to clarify that for him. We're also really careful with euphemisms. The biggest, most common one used here in the hospital setting is put to sleep. It's a pretty common phrase when talking about anesthesia. Anesthesiologists say it, we hear the medical staff say it frequently. But for a child who lost their dog last week and is having anesthesia today, that put to sleep has a very, very different meaning. So we want to be careful about things like that. And that's why we work really hard to make sure that we're providing information that is clear and not confusing to children. This is kind of a more difficult to clarify genre of our role, supporting children, because everybody supports children. everybody here at the hospital does. But some of the support that we as child life specialists provide are talking about the tough things. So anytime something difficult is happening or going to happen, we can initiate that conversation or provide some support for that, whether it's a transition to another hospital for further treatment, or hair loss, or difficult sibling relationships due to the illness. Currently, COVID has been a big topic here. Our patients are hearing about it in the news. They're learning things about it. They know that they're considered high risk. So they have a lot of questions and a lot of concern. We help children navigate transitions, like transitioning to another hospital, as I mentioned. We teach coping mechanisms, prepare children to handle those difficult situations. That might be going back to school for the first time. It might be talking to their friends about their illness. We do a lot of role playing with children to give them a chance to learn wording that works for them when talking to other people. We use a lot of bibliotherapy, a lot of books to help children as well. Let's see. This was one of our activities, just a general supportive activity, a Dear Cancer letter that I did not provide any prompts with. I just wrote Dear Cancer and somebody corrected me. And then I left it in our clinic playroom for a couple of weeks and let this happen. And it was really interesting to see what each child wrote and how they're feeling. I mean, they don't hide how they're feeling, but to see it down on paper was really powerful like this. So just some of the books that we like to use. Some are cancer specific and some are not. Beautiful Bald Princess is about hair loss in general and can be helpful to girls with alopecia due to many different reasons. And then Wilma Jean the Worry Machine is one of my favorites for helping children work out some anxiety and try to understand the difference between little worries and big worries. Another thing that we do to help children is procedural support and distraction. So unfortunately, the cancer experience does come with a lot of painful procedures, uncomfortable procedures. And we try to work as a healthcare team to make sure children have as much comfort and relief from pain as possible, but it's not always possible to eliminate everything. So we do a lot of distraction and support as children are having procedures, whether that's a blood draw or a spinal tap, using iPads and iSpy books. We used to be able to use bubbles, but COVID has kind of stopped that. A lot of talking and supporting through visualization. We always encourage parental involvement and positioning for comfort, which allows children to maintain as much control as possible, to be held in an upright manner, not laying down with everybody on top of them, kind of thing. A lot of verbal coaching and rehearsal to get through procedures. Just trying to be aware of time here. One of the very basics of child life practice is play, because we know that, as Erickson said, play is the most natural method of self-healing that childhood affords. And play is how children learn, it's how they master challenging situations, it's how they cope, and it's how they communicate. It aids in social, emotional, and cognitive development. We know that pretend play in particular helps children learn self-regulation, narrative recall, divergent problem solving, understanding of rules. And when children are in the hospital, we use some different kinds of play. We use normalizing activities to help them still be kids, because our motto is that kids are kids first. They just happen to have cancer, our patients at least. And we want them to feel like kids as much as possible. Play has therapeutic benefits, and we'll talk about that. And play also allows continuation of developmental skills, because play is what children should be doing to be continuing those developmental skills. Here are some examples of therapeutic play. Therapeutic play is used for exploration of emotions and tough situations and to support children. We have a duck here. This is the Affleck duck, and he has emotions, and I'll just play just a quick snippet of this. But this is a way children can learn to name emotions and learn to cope with emotions, as well as be able to show us how they're feeling on their duck if they can't find the words for it or aren't able to say that. So this duck is a little dramatic, so I apologize, but here he is. So that's loud. Again, a little dramatic. Each of the ducks responds a little differently, which is always funny. But that was a duck feeling sick, a duck feeling sad, and a duck feeling silly. So the kids really seem to get a lot out of this tool. We don't always need fancy robotic ducks for our therapeutic play. These on the right side of the screen, we have our MAD targets. So we make targets with listing things that make us upset. And then we wad up wet tissues and throw it at it. So there's kind of a disgusting picture there showing that after effects. The first one was done by a 4-year-old who has really varying things that make him angry. A lot having to do with watching YouTube and not watching Baby Shark. And then we have a MAD target by a 9-year-old girl who is really bothered by her sister being annoying. And then when she can't watch TV, hence the black screen, and then a little port needle over here for when she gets her port accessed. So these are great ways of children to explore those emotions and to talk about the things that are upsetting them, which aren't always the things that we think. I wouldn't have thought Baby Shark would make a child so irate, but it beat out all the medical stuff. Oh no, that's playing again. Okay. So another form of therapeutic play we do is medical play, and that is because children do learn the best through play, and we can assess a child's understanding and misconceptions this way. It allows for children to gain mastery over the tools and procedures and become familiar with it, hopefully lessening their fear. We have some examples of medical play here. We have a lot of tools available to us here. American Girl has been great with some of their medical themed things, but we do a lot of our own loose parts play as well to make our own, like our dinosaur here with this port. If you are a doll, dinosaur, animal, or even pumpkin in our playroom, you will end up with a port and be used for medical play. We have a teaching doll here, and this teaching doll is actually getting acupuncture to help with the side effects of her chemotherapy per a couple of our kids a couple years ago. And then on the other side of the screen, sometimes the really scary things here are not what we think. So this is actually a pretend ear made of Play-Doh. And we looked in this ear maybe 60 times within a few minutes to try and get some comfort with looking in ears, because that is more terrifying than having an IV for some of our children. We have our doll receiving chemo, pretty common sight here. And I'm a big fan of water play, and it helps children be able to actually see how the IVs work. This was a patient who had a really hard time, who would get upset with the nurses and would tell them to flush it slowly, and would always say that you can go slower, and they'd be like, we can't. So this allowed her to see exactly how fast that liquid was coming out, and that you can only go so slow with it. And it made her much more comfortable with the procedure after that. We also do a lot of medical art. So syringe painting is a risky, if you don't like mess, but really fun and rewarding way to become familiar with one of the scariest pieces of medical equipment. Band-aids are fun for everybody. We do a lot of that. And then we do a lot of just drawing as well. So this was a drawing by a 5-year-old with leukemia who wrote "no bad cells." I was a little alarmed at first because I thought it meant no bad child life specialist, but she said cells. Just a note, as child life specialists, we tend not to use the word bad in reference to the cells or a child's body, because we don't want any confusion of blame or assigning that they did something bad to create this. But the children often come up with that phrasing on their own. So she did that, and she actually drew a whole series throughout her illness of those bad cells, and then she had the chemotherapy attacking and those good cells coming back. That was great. I'm just not sure about time right now. If I get to...
You've got like 17 minutes.
Okay,
That's
great.
okay. Yeah.
Great. Okay, thank you. I wanted to talk about school because that's why a lot of you are here today, and that's the whole point of this conference. Our children are out of school for great amounts of time. They could be out for a couple months. They could miss an entire school year. And our little one, or our school agers, not our little ones, and our adolescents are entitled to homebound instruction for the state, and they get that, but that's often not enough to keep up with their peers. Our kids often fear being left back, falling behind, not being able to keep up when they go back to school. A lot of fear of losing social standing and being forgotten by peers. So we do a couple of different things to hopefully help children as they're dealing with being out of school and then as they're going back to school. We do classroom visits to help students understand what's happening. A lot of rumors can start when a child is out of school for a long period of time. So we get permission from the family, from the school, and often from the other parents of classmates to be able to share what's going on with the class. Prior to COVID-19, many of our patients used a robot to attend school. The robot was in the class. There's a link that you can access if you have the slides. I'm not going to show the video now, but that kind of explains what the robot does. And the children could control that robot from home using an iPad and be a part of the class as much as they were up for and able to do each and every day. Now, all of our children have the option to go remotely anyway, so we're not using the robots at this time, but we hope that hopefully pretty soon kids will be back. We do have a position in our center, an education liaison who works as a link between the schools and our center, and her job is to meet with schools, provide information regarding the diagnosis and treatment, to support the school and support that family in everything regarding education. Introducing the robot to the school, making sure that that's working. Unfortunately, our education liaison did pass away this week from her own cancer battle. So we're kind of trying to figure out just which way is up right now. And I included this in though, because she is such and has been such an integral part of our team and has made such a difference for our kids going back to school. Having that link between us and the school is so great and saves a lot of frustration for the families, helps the schools to get a better understanding of what's going on, and allows us to provide each child with the best education that we can while undergoing the cancer treatment. Another thing we do, oh, I talked about classroom visits already. Sometimes schools are reluctant to allow information, but we do know that children often know more than we think. I did go to a school visit a couple years ago and I was asked not to use the word cancer, which is not uncommon. Again, it's a really scary word for grown-ups and we try to advocate for the use of it, but in the end, it's really up to that school or that parent. So I went in and I asked the children if they knew why their classmate had been out of school. And every single one of them looked at me and they yelled, "Yeah, he's got cancer." Like, oh, okay. They already know this. So they're often hearing a lot of the information. And we find that correct information is necessary to prevent rumors, to help with any fear, and make sure kids are not forgotten, because we want them to come back and be a member of their class. Let's see. When children are returning to school, they can experience a lot of cognitive effects that may happen right away while they're on chemotherapy and may happen later down the road. They may have difficulty with processing of words and numbers, memory. These are things that our center tries to help children with. We do have a neuropsychologist on staff who does testing with children to identify needs. And we know that these educational needs may be lifelong and may affect a child for their entire schooling career and then their actual career after. And also important to note that every child is an individual and may have different needs. Again, this was pre-pandemic slide. Children have different needs when they're returning to school while still on treatment. Right now, our children are not returning to school on treatment, even in districts that are split or have the option. Our children are staying virtual. That said, we still find that they have some different needs from their classmates when they're undergoing treatment and still doing virtual school. Most of the kids are actually happy about virtual school because they say that finally everybody is doing it their way. Everybody knows what it's like to be doing school from home. It's kind of, it's nice to hear that they're feeling positive about it, but it does reinforce that isolation that they were feeling prior to this. And of course, we don't want to celebrate a pandemic, but it's just an interesting thing to hear them say. They still may need some accommodations. They may not be able to have their video on all the time. They may not feel up to showing their face. When we have kids logged in here at clinic every day, I'm trying to adapt to virtual school now because I'm used to going up to kids and being silly or telling jokes or doing something really crazy. And then all of a sudden I'm realizing I'm on screen and their whole class can see me. That's not great. So they may need the option to turn that screen off if something is going on, if they're not comfortable here. If there's a chance that other patients may be seen, we do tell them to turn that screen off. They may need to have water and snacks available because of their physical needs. They may need to be absent even though they have the ability to log on. If they're in the hospital, we don't have the greatest internet. They may feel pretty lousy. So just some things to keep in mind if working with a family where a child is returning to school while still on treatment or shortly off treatment. So really quickly, we'll talk about how schools and communities can help. Families are often overwhelmed at diagnosis and unsure what their needs are. Sometimes if you ask a newly diagnosed family, what do you need? They have no clue what would help them at that time. Common needs are childcare for siblings, general support, help with practical tasks, and financial needs. Some common threads we hear are not just childcare for siblings, but rides. Oftentimes siblings may be cared for, but they might miss out on those extracurriculars, those birthday parties, all those things that children would be attending just because mom or dad can't take them. So it's great to be able to offer rides, even if you're not taking a child for a whole day, but just give them that ride so that they can still be a part of that activity, or including them in things. A lot of our parents say an ear to listen to is great. And then narrowing that down even further, they often need somebody who's willing to hear the harder things. A lot of people are greeted with a response of, oh, that's too sad, I can't hear about it. And that can be difficult to hear, to feel like you can't share how you're feeling because it's too sad. Sometimes help is needed with practical tasks like mowing the lawn, grocery shopping, dropping off items to the hospital. Dinner trains are really helpful now, and it's really great that we have all those websites to help. In the time of COVID, we have very limited visitation at the hospital. So a lot of our families have benefited from people who could just drop something off and don't get offended that they're not able to come in and see the child, can't come in and give them a hug, as long as they're okay with just dropping that stuff off, whether it's food or clothes, clean clothes. Clean clothes are huge for the hospital. Big deal when you don't have clean clothes. The financial aspect we discussed earlier can be pretty brutal. So things like gift cards for food are an easy way to help somebody without making it into a big thing. Gift cards for gas because they're on the road all the time. Some schools and communities will start fundraisers for families. It's always great to connect with a family if it's a member of the family directly or somebody who can be a liaison between the family and the school or the community group, just to know what they're comfortable with too. It's really, really hard to accept help. And we work with our families to help them understand that by them taking help, it's actually making the people who are offering feel good, because it's hard to feel like you can't do anything and you want to help. And at the same time, it can be really hard to accept that help. So always good to sort of feel out what might be helpful before just slamming them with it. That goes along with the get guidance from the family. Gift cards are really easy for schools to do. School equipment. So prior to this, when kids were out of school, they might not have had that Chromebook that they needed or an iPad or something. And that's been something that schools have been helpful with in the past. Watching out for siblings, making sure to still identify that sibling as him or herself and to treat them as him or herself and not just an accessory to the sick sibling. Some schools have participated in events, whether it's a walk for a hospital or for childhood cancer awareness. Sharing information is often difficult for schools, so it's important to connect with the family and find out what is okay to give out. If you are doing something for a family, how much information is really okay. And the most important thing is just be willing to work with families. Be willing to hear their needs and try to accommodate those needs as much as possible. Nobody wants to be in this situation. Nobody wants to be fighting for what their kid needs because they're dealing with cancer and school at the same time. So it can be very helpful to just be open to hear their needs and provide anything you can to help. So when treatment ends, that's all that ends, just the actual treatment. The rest doesn't end. It's often a high anxiety time for parents and patients. The safety net of treatment is gone. So anxiety can skyrocket. We help families transition to follow-up care, and we continue to be available. We provide continued support and see children for follow-up medically and psychosocially. We have a long-term follow-up program because we know that over 60% of patients have long-term effects, although that is very low, as I mentioned earlier. A very recent figure from St. Baldrick's states that over 90% of survivors will have a chronic health condition by the age of 45 as a result of their cancer treatment, which is a huge number. That's kind of mind-blowing. Even seeing this every day and seeing the effects, seeing that number is very disheartening. We do continue treating young adults with cancer. We don't transfer them to adult care. They stay with us for the length of their treatment and even for follow-up. We do unfortunately see children who relapse, and that often comes with more intense fear, more intense feelings. Knowing what to expect does not make it any easier. This figure here, 1 out of 7 children will not survive, is actually probably not accurate. The current figure is more like 1 in 5, but this is the last stat that I had documentation for. So that's why it's listed. But now it's looking like 1 in 5 is probably more accurate. We do bring in palliative care and hospice care when needed, but we also provide a continuation of care by the primary oncology team. So we're with families through diagnosis until pretty much we don't say goodbye to families. So whether that's ongoing care through our long-term follow-up or ongoing care for a family through bereavement support, they find it hard to shake us. As a child life specialist, as a child life team, we provide support to our children with cancer who are facing end-of-life care, and also consult services to adult units when children are involved. We advocate for education or for information. We provide education. We do memory-making activities and legacy-building activities. Nothing makes it okay, and nothing makes it better, but we do what we can to continue to offer something at that point. I know that there will be another talk during this conference about grief, but I did want to mention that grief is not limited to death. Grief is something that occurs as a reaction to loss, and we see a lot of grief throughout the continuum of diagnosis. So we see a lot of grief at diagnosis. We see grief for what life was and what it was expected to be, whether it's what a parent wanted for their child or what that child wanted. We see grief when the prognosis changes as things are lost, and that could be if a child, for example, is so impacted by their treatment that they no longer can return to the sport they loved. There's a lot of grief surrounding that, as well as anticipatory grief for upcoming changes. We also know that children display grief differently based on their developmental stage, and I won't get into that because that's a whole other presentation, and you'll get that during this conference, I believe. But we do think that it's important to provide developmentally appropriate information and be aware of developmentally driven reactions to grief. Everyone who works with children will come in contact with a grieving child at some point, whether that child is grieving a loss due to death, divorce, an illness in the family, anything like that. There will be grief. And this, I left the change here because I had originally put grieving children need to know what grief is and that it's normal. But that really, and then I changed it to grieving people, grieving humans, because everybody needs to know that it is normal. It's not fun, it's not pleasant, but it is normal, and it's a normal reaction to any sort of loss. So there's not a good transition from that to the end. But I also included a couple of websites for up-to-date information, as well as a really powerful video, Paul and the Dragon. It's available on YouTube. That shows, there are no words to it, but it's an animated video about a child's experience with cancer, and it's very, very powerful. So I encourage you to watch it if you have some time at some point.